Danie van der Merwe. He qualified as a medical doctor from UP in 1991, and he proceeded to work in the Department of Family and Emergency Medicine Unit at Kalafong and Pretoria Academic Hospital, and obtained an MMed in Family Medicine in the year 2000. He also worked as a Supervising Medical Officer with Gauteng Emergency Medical Services and obtained a Diploma in Primary Emergency Care, which was the highest qualification in emergency medicine in South Africa at the time. Dr. van der Merwe then spent the next 5 years in Canada, working in various major emergency departments in Manitoba and British Columbia, gaining valuable experience. After returning to South Africa, Dr. van der Merwe spent the next 10 years in various emergency departments in Pretoria before successfully taking over the newly established Mediclinic Midstream Emergency Centre. After 5 years at Midstream, he teamed up with colleagues, Dr. Bianca Vermeulen and Dr. Schalk Augustyn, managing the emergency centre at Mediclinic Brits, as well as the accident and emergency unit at Raslouw Private Hospital. Dr. van der Merwe is also a qualified airline transport pilot, flying for the air ambulance service in his spare time. So thank you. As always, we appreciate you coming to present to us.
Thank you, Leanne. Thank you, Leanne. It's always good to spend time preparing a lecture and learning in the process. So I was recently asked to present this lecture to a group of GPs and specialists at Raslouw Private Hospital. It was just a local presentation. It wasn't online, so I thought, well, this would be a perfect platform just to do a presentation online. And this, by no means, I'm certainly not a virologist. I'm not a specialist in tropical diseases, but we all are now introduced again to new outbreaks of the hantavirus, and then of course Ebola that's now currently making headways. So it'll be an interesting opportunity for us to just update our information and learn a little bit more in the process. Okay, first of all, it is quite a severe illness, although rare, and there are, the outbreaks typically is a fever, gastrointestinal symptoms, multi-organist failure, hemorrhagic symptoms, and ultimately death. And mortality is extremely high depending on the strain, but it's very dependent on how early intervention can be started. So there's a bit of background. It gets its name, like most viruses, gets its name from where it was first found or discovered in the DRC, in the northern DRC, the Ebola River, which was translated to Ebola, near the village of Yambuku, a really remote, 100 kilometers north of the Ebola River. And that's where it got its name from. And just a bit of a perspective, because we hear the name Ebola, we don't even, you can see there where the Ebola River is. And that area is where the first outbreak was documented. So what is the Ebola virus? We all remember the famous COVID-19, which is a coronavirus, and this is a filoviridae, and it's the name from the Latin word means it looks like a filament on the electron microscope. There are 4 strains. You get the Zaire strain, which is the most common one, as well as most deadly one. They get the Sudan strain, which was discovered simultaneously with the Zaire strain. A little bit less fatal, but that's mostly in Sudan. The Bundibugyo Ebola virus, which is the current outbreak, that's usually in Uganda, and it's slightly less fatal. And then there's a few others not very significant to humans. So the first I recognize the outbreak in 1976. Now the technology and the measures to fight it in those days weren't as sophisticated as today, but that was the first one. So that was 318 cases with the Zaire strain, with about 88% mortality at that time. The Sudan strain, a little bit less virulent, 53% mortality rate. There was various outbreaks over the years. approximately every 5 years there's an outbreak. Then there was the bad one, the West African one, and that was in Guinea, Liberia, and Sierra Leone. They didn't expect it there. They were ill-prepared, very densely populated areas. The mortality rate was extremely high, and mostly due to a very late response, with 11,000 deaths. And the average fatality rate of about 40%. And then there's a few more outbreaks, and then we get to this just to show more or less on the map. You can see it's a Central Africa, very tropical area, densely populated forests and very densely populated cities. Now, the current outbreak is the Bunubuyo strain, and there's mostly the majority in Ituri province and the northeast of the DRC, as well as slightly less in the north and south Kivu, also along the eastern border of the DRC. So far, now in this statistics, every time I do the presentation, I update the statistics. So now we're standing at 630 cases of 120 confirmed deaths in the DRC. So it is expanding. Neighboring Uganda, a few spillover cases, that hasn't changed much. Just to show the map, this is, you can see there the DRC adjacent to the most beautiful Lake Edward and Lake Albert. And there's many from the website also on this attending us. We were actually flying out of Arua, which is right there on the opposite side of the border, literally, I think 180 kilometers from Bunia, which is now the epicenter of this outbreak. And we must remember that the villages, they don't see the borders, so they move freely across the border in local communities, and that kind of can accentuate the potential spread. Now, this is just to give you an idea. This is Bunia on the left-hand side, and this is what a city there looks like. 900,000 people in a very densely populated but third world country with very little facilities. On the right-hand side, you see the opposite in those very dense forests. And we had a privilege to fly over those forests. And we always tease and say, if your aircraft goes down over those forests, it'll never find you. Now, this is where those people live. Very difficult to access these areas, but also in very close proximity to the animals that carry these viruses. And you can see this is Bunia Airport, very modest building, which was close now during the epicenter, and they actually make use of Arua on the opposite side and other airports around to fly help in. So now looking at the reservoirs, it's a fruit bat. It's not a cave bat, so they live in the trees right above where these people live. You can just imagine. And then the further, these viruses are then transferred, spilled over into the Western Groland gorillas. You know, a lot of people go to Uganda, to the Lake Albert region to actually see these gorillas. It's like a yellow crested gorilla. You get chimpanzees, monkeys, you get the forest animal. We all know the duiker, we get the blue duiker in South Africa thing, and there's a striped duiker there. We must keep in mind, these gorillas, the monkeys and the chimpanzees, has just a high mortality as humans because of their close genetic development to human beings, 99% DNA comparison. So they quite often the first signs of an outbreak is finding these dead animals in the forests. And you can just imagine that these people live in very proximity to these animals, and therefore their feces, their urine, contaminate the water and the food supplies. Also, they live off these animals, and they find the carcass, they often sacrifice it and they eat it, and that's how it gets transferred even further. So direct contact, working with these animals, just like working with a corpse of a person, makes it highly transmissible. Then eating the contaminated meat, when they either slaughter asymptomatic animals or they eat the dead animals, and then the environment with the contamination of urine, feces, the drinking water, saliva, and all that kind of bodily secretions. Right, person to person, once it's in humans, it spreads through fluids, not aerosols. It's not a respiratory virus. It makes it less contagious for the general population, but highly contagious for close proximity when you're working with these people. So in other words, saliva, blood, vomit, diarrhea, urine, not so much perspiration, but any secretions from the body, semen and breast milk as well. A big problem is burial ceremonies. When the people die, their local community wants to take them back into the community for the burial rituals, where they put them on display and they hug them and they touch them. And there's been a few cases where hospitals were actually burned down because the health authorities didn't want the community to take the bodies back. And of course, during hospital procedures, when you do procedures, you can actually cause spread. Right. Once you get, for you to get it, it has to go either through your mucous membranes, which is most common, eyes, nose, mouth, and then, of course, any open wounds. So the incubation period, and this is tricky, so the incubation period can be anything from 2 to 21 days, depending on the mode of entry, the viral load, the immune response of the individual. And the problem with this is that it's completely asymptomatic, but so it's not transmissible when you're in the incubation period, but you also can't test for it in the incubation period. Right. So just a little bit about and this is a general description, but specifically, again, this is a RNA virus, a single-strand RNA, which makes it a very unstable virus because there's no checking system and they can get a regular mutation. So basically, the virus, and it's ironic to think that the virus is not actually really a living organism. It's simply a packaged RNA with the viral polymerase, which is basically the instruction manual, into this that attaches to the cell membrane, to the glycoproteins. The glycoproteins attaches to receptors. The contents is dumped into the cytoplasma. The viral polymerase then converts the negative sense RNA to positive sense RNA. That is then used to make more viral proteins, thousands of these. Then once it's got enough viral proteins, it makes new negative sense RNA. This is now surrounded by a viral proteins in like a nucleocapsid. It goes to the membrane, breaks off a piece of the membrane, wraps it around in an envelope, and off it goes, destroying the cell in the process, releasing millions of these viruses. So it's quite an aggressive replication. This is just like a rough illustration. Goes into the cell, does it work, and then leaves the cell, destroying the cell in the process. It's so good at survival because it hijacks the cell, it reproduces very rapidly to massive numbers. Because it's unstable, it mutates frequently. It makes, in other words, it makes fighting it very difficult. It evolves continuously. It avoids your immune system to be able to destroy it earlier. It can remain in the body, especially in the semen, for instance, for a very long time. And because of the mode of spread, where people are densely populated, this is where it just basically explodes. Right. So the immune system that's attacked by it is the monocytes, dendritic cells, and macrophages. And the problem with this is very much like an allergic reaction, is that you get an out of proportion response, like we saw with the COVID as well. When you get a high viral load, you get a cytokine storm, which means that your inflammatory and immune modulators overwhelms your body. And it's an out of proportion, uncontrolled response, and it causes damage to the tissue. So first of all, you destroy the cells, you destroy the endothelium, you get capillary leak. So there's a few ways it causes the coagulation abnormalities. First of all, it loves attacking the liver. So you get liver damage and therefore decreased coagulation factor production. It causes thrombocytopenia, which further reduces your clotting mechanism. And then together with the renal failure and the distributive shock, it just aggravates the whole situation. Also activates your clotting cascade. So it exhausts your clotting factors in your platelets. And then eventually the cause of death is severe kidney failure, shock, multi-organ failure, and with that as well, DIC, hemorrhage, and eventually death. So the clinical features, like we said, in the incubation period, there's no symptoms. The maximum is typically 3 weeks, and so that would be the observation period of close contacts. During this time, we call it the prodromal period, but on this incubation period, so it's completely asymptomatic, but you can't test for it either. Then you get a prodromal period, which is, and you can just, if you look at this, you can see this is a very non-specific. This is like in the winter season, most of our patients with fever, malaise, body aches and pain, sore throat. I mean, there's no way to say that you're dealing with viral hemorrhagic fever at this stage. That's why with every person with fever that comes into this country or presents to the emergency department, we need to ask about travel history and contact history. This is the only way at this stage you're going to pick up a high-risk patient. Then you get your gastrointestinal phase, almost like cholera. So this is, and this is the big problem. They develop like gastrointestinal symptoms with severe vomiting and diarrhea, profuse diarrhea. With that, invariable stages of abdominal pain, and that's going to be caused by affecting the liver. It can be caused by swelling of the gastrointestinal wall, by cramping, by leaking of fluid into abdominal wall, peritonitis, so in other words, different abdominal clinical pictures. Ultimately, severe losses, and this contributes to the distributive shock that you go in, or the hypovolemic shock, and this contributes to the eventual fatality. This is where, if you intervene here, give them aggressive fluid and electrolyte therapy, you can improve the prognosis. Severe disease, if it's unattended by the second week, you can see here, well, your organ failure starts to happen, your volume depletion starts to happen, and you're really in big trouble. Now, contrary to what people think with Ebola, if you compare it to Congo hemorrhagic fever, the minority of patients actually gets hemorrhagic symptoms, only 15%, and only late in the disease. So in other words, you're not going to see a patient walking in your emergency department with petechiae and purpura. They're going to walk in there with flu-like symptoms and gastro symptoms. That's what you need to watch out. Don't look for hemorrhagic symptoms. You're not going to find it. This is going to develop later on in hospital. Hopefully not our hospital. Because we'll talk about how these patients, when they need to be transferred and who has to manage them. When does a patient become infected? Like we said, when they develop fever, in your first symptoms. When they start developing secretions like diarrhea, vomiting, bleeding, that is when the viral load is extremely high. And this is, we have to be very, very careful in managing these patients. Laboratory findings. Okay, so typically, initially, a leukopenia will develop. After that, leukocytosis. Thrombocytopenia, not as bad as Congo hemorrhagic fever, but still the platelets will be low, and that contributes to the DIC later on in the disease. Because the liver is affected, you'll see elevated liver enzymes and bilirubin. Eventually develop a coagulopathy. You need to monitor for that. Metabolic acidosis, lactate because of circulatory shock, and kidney failure. Diagnostic tests. Now, this is what helps communities identify these patients early on in the symptoms. There's a reverse transcriptase PCR, and you can do this as a rapid test. Now, keep in mind that the average, the hospitals in South Africa don't keep these tests in the lab because it's very rarely required. Only the NICD can do these tests. In other words, when you identify a potential case, you need to notify your infection control of your hospital. You need to notify the NICD via the helpline, the hotline, which we're going to mention later. And they will then arrange for the samples to be transported to the NICD where they'll test it. Turnaround time can be as much as 24 hours. Hopefully sooner we can just get the process going quicker. You can't just ask the lab for a quick PCR test. Right, dangerous goods. This is because this is highly contagious and because it's a blood product, in the transport of dangerous goods, there are very specific regulations. This is class 6 now. This is a biohazard, and it's got a triple packaging. So you got your tube inside, absorb-proof material inside the bag, inside a box that's sealed. So there's no way, even if you drop it from the first floor of a building, it's not going to burst and leak. And then it gets a very specific biohazard label on, and with handling instructions. And the transport companies has a specific process in terms of transporting these samples. You just don't put it in a courier and just send it over. So when we get a patient to the hospital, the first thing you do is, because we don't know much, you give the patient a surgical mask, you put them in an isolated area. All hospitals are required by Department of Health to have an isolated isolation room. But you can use any room that you, in your emergency department, that you are able to isolate, but it should have a toilet facilities or washroom facilities, because you don't want these patients to come out and mix with other patients. Limit your staff contact. Now, there's one doctor, one nurse assigned to this patient. Use full PPE, and we'll describe it now. Notify INCON, the infection control, notify the NICD. And I tested the NICD hotline, and it actually really works. So these are the PPEs. First of all, when you identify a patient, so typically, hopefully it will be in the early stages of the prodromal symptoms. So this is very similar to what we did in COVID. So in other words, you use a fluid-resistant long-sleeve gown, gloves, surgical mask, eye protection. You could use foot covering as well. This is just to have some basic interaction with your patient. I'm talking about full-blown procedures. If you are now going to be involved in the patient care, you need to have, so the first one is a splash-proof gown. This is an impermeable gown, because things can't soak through this gown. Double gloves, face shield, hood, goggles. On top of that, another waterproof apron, boot covers, and then you can use a surgical mask. But if you're going to do aerolizing procedures, then it should be, you can do N95 masks, and some, like if it's going to be surgical procedures, there might even be a respirator. Now, the donning and doffing, we've practiced this extensively during COVID. And we tend to think about donning and doffing as doing PPEs for a surgical procedure. And we do it all very meticulously until we doff, and others remove it. And we just grab everything and rip it off and throw it in a red bin. The problem is I found that most transmission occurs when we remove the personal protective equipment, because it's so technical that if you miss one step, you're going to contaminate yourself. In other words, the principle is basically that you remove an item and you sterilize. You remove the next item and you sterilize. So your gown and your first layer of gloves sterilized. Remove your mask in a very particular manner, your hood and everything, and sterilize. Between every stage, you sterilize. And they found that you should have a trained observer guiding you through this process. Then furthermore, you have a contaminated zone where you remove your first layer of clothing, then sterilize. You go into your intermediate zone, you remove what's supposed to be the clean underlayer of clothing, but there's a small risk of contamination into that zone. And then you move out to the clean zone. The guidelines are all on the NICD website, and INCON should be able to guide us in this process as well. So the waste management and the sample management, obviously, that needs to follow specific procedures. Then, in terms of managing these patients, aggressive fluid therapy as early as possible. It's like treating a burn wound. If you do aggressive, appropriate fluid therapy from the beginning, avoid complications later on. We start with aggressive fluid resuscitation, but then we correct it according to our lab results. Correct electrolytes, correct your coagulation abnormalities, keep vasopressors where necessary. We spoke about vasopressors last week, and prevent secondary infections. So typically for fever, we'll give paracetamol unless we know there's liver failure. In general, in the first prodromal phase, you might give NSAIDs because you won't even know if it's Ebola. But once there's any evidence of coagulation abnormalities later in the disease, we avoid NSAIDs. We also want to avoid it when there's a shock evolving. Specific therapies. This is now very theoretical because it's not applicable to the current outbreak. You get a monoclonal antibodies that's used for the Zaire Ebola virus, which basically is designed to recognize the glycoprotein. Remember the glycoprotein is the little spike proteins that we saw on the coronavirus? Now, all viruses have them. They are very unique to every virus. And it locks onto this glycoprotein so that it doesn't bind to the cells, can't enter the cells. And there's a few of them available. Certainly not in South Africa, but they are used for close contacts or early detection in high-risk areas. And then vaccines. This is specifically used for the so it's not because it's such a rare outbreak. We don't vaccinate the general population, only close contacts in the area. But again, there's no vaccine against the Bundibugyo strain. And the reason for that is during those massive outbreaks in the past, they were able to develop a vaccination, but the Bundibugyo strain wasn't known then. And the Bundibugyo outbreaks have been fairly mild, so they've never been able to develop a vaccine against it. And the current vaccines is not effective against the Bundibugyo strain. You see, that's a difficult thing in treating or vaccinating. So there's two. There's the initial one. So the Rebo vaccine, which is a single one, and then there's the 2-dose one, similar to what we have against COVID. So what they're now developing is to use the platform for the previous Zaire strain and develop it for the other strains as well. The typical platform for COVID-19, AstraZeneca developed that. And then, of course, there's a very controversial mRNA platform where you could potentially develop a vaccination fairly quickly and adapt it for different strains with minimum effort. That's the future. The challenges with vaccine, everybody's asking, well, why don't we vaccinate everyone? Why is there not vaccines available? The problem is, as you know, when COVID was very easy because there was millions of people. The problem is, first of all, the outbreaks are rare, unpredictable, and very remote with very basic facilities. So it's very difficult to conduct a trial. You can just remember those pictures. You want to conduct a trial in that environment. It's going to be very challenging. Plus, you've got multiple species. You've got 6 different species. You need to have high safety standards, which is difficult to maintain there. And the animal reservoirs still remain there, and they continuously mutate. So that makes it very challenging. So multivalent vaccines can be developed in future. mRNA vaccines can be developed, but it's not applicable to us. Mortality rate typically can be up to 90%. Average of about 50%, and that's typically the happy place for a virus. It doesn't want to kill most of its host, it just wants to kill half of it so it can continue to exist. The virus just wants to survive. That's all it wants to do. It wants to survive and replicate, and then it's achieved its goal. So mortality depends on the species, like the Zaire strain, how quickly you can get to care, how effective you can manage them, and of course, age and comorbidity is very important. Just like COVID, you get long-term complications like chronic fatigue, neurocognitive symptoms, body aches and pains, depression. A lot of people from COVID has reported it as well. Just keep in mind, it can remain in the eye, the fluid inside the eye, your testis, and even your central nervous system for long periods of time, where you almost become a carrier. Then a differential diagnosis of Ebola viral disease. Of course, common things being common. We're going to get much more other. I mean, we can get influenza, like it's an influenza outbreak now. We get malaria on a regular basis, typhoid fever, any other bacterial sepsis. In Africa, you get all the other types of hemorrhagic fever, the Lassa fever by rodents, the yellow fever, by mosquito. you've got meningitis. So there's many other conditions we still need to keep in mind. And just a quick word on Krim-Congo hemorrhagic fever, because whenever you speak about hemorrhagic fever, Krim-Congo hemorrhagic fever comes to mention. And very interesting, I asked myself the question, why do we call it Krim-Congo hemorrhagic fever? I was very curious to learn that the first outbreak was in the Second World War in Crimea, which is very much in the news now after Russian annexation of that peninsula in the Ukraine. And then in 1956, there was the first outbreak in Africa, near Kisangani. And only in 1969 did they realize it was actually the same virus. And that's why they then gave the name the Crimean Congo hemorrhagic fever. What we don't realize, it's actually endemic in South Africa. It's not a Central African condition. And it's typically in the Northern Cape, Northwest and Limpopo, where cattle farmers, where it can be is carried by a specific tick, then where the animals can be affected and become carriers. And then close workers with these animals can become infected. These ticks don't commonly bite humans, so that's why it's not as common. And there is regular outbreaks. So in the past, since 1981, we've had an average of about 5 or 6 outbreaks per year. But fortunately, the Veterinary Society in South Africa keep very close tap on this.
Really?
Where is this is slide presentation?
It's coming.
Sorry, we just lost internet connection, so we're just going to reactivate.
Stay online. We love you, people. Section cut off completely.
Yes, I was wondering.
It was going so smoothly.
Why should we have a session about complications?
Stop dreaming about this.
Check the voice.
Mine's almost done. Okay. Yeah.
How do we? Oh, there we go. Fantastic.
Okay, we're now 56.
Just go to the last one.
Physics, yeah.
You start to get now again.
This is just a quick review.
Yeah.
Yes, I know. Yes.
No.
Fruits.
Only.
Yeah, fruits there.
Anybody need oats?
No.
How's that?
Too fast now.
It's going to be 36. Click 36. Okay.
Yes, yes, yes.
Yes. There you go. Yeah. Brief, guys. Sorry, we're almost there. Yeah, there you go.
Okay, so yeah, we were speaking about the Crim-Congo hemorrhagic fever versus Ebola. So the Crim-Congo is a norovirus, is a different virus altogether. In this case, there's severe thrombocytopenia, a history of exposing to these animals, and tick exposure. And this is a more pronounced hemorrhagic fever, whereas the Ebola is more gastrointestinal symptoms, and you have to be in contact with somebody from the high-risk area, or traveled yourself. Right, so with the current outbreak, the Bundibugyo strain, like we said, so far it's I think it's about 630 cases with 120 confirmed deaths. So since I first produced the slide, it's basically doubled. And then some in spillover in northern Uganda. The problem that we have here is there's no monoclonal antibodies for the treatment. There is no vaccines available. Then in those parts you get Codeco, which is the cooperative for the Democratic Congo. That's like a war faction, Lord's Resistance Army, and the March 23 rebels. It's all active in those forests, which makes healthcare providers going to that area very difficult. The community don't trust healthcare providers because they never see them, and then they get an outbreak, and then suddenly the place is full of healthcare providers wanting to give them treatment and take the bodies away. So they're very antagonistic towards healthcare workers. And then, of course, the cross-border movement of populations. So it could be just be a question from time, because this is widespread in Uganda and southern Sudan. Just a recap, the Bundibugyo fortunately is the least dangerous of the three, if you can, but that's a very relative term, with this up to 50% mortality. So one thing we need to keep in mind, this is not an airborne virus. In other words, you can't just walk past somebody and contract it like potentially with COVID. You have to have physical contact with these people or their environment, in other words, bodily fluids. And that makes it not less dangerous, but less contagious for the general population. The advantage that we have is that we've got rapid PCR testing that we can do in the community, identify early cases quicker, isolate them, treat them effectively, and thereby limiting the spread. Of course, there's still the asymptomatic early 3 weeks where people can move around and outside that area and potentially spread the disease. So just as comparison, remember we were faced with R0 values, or RO values very, very frequently during COVID. And so just as a comparison, measles, the most contagious viral condition, with a RO of 18, and the Ebola is 1.5. Influenza is about 1.8. So that gives you an indication. But remember, influenza is a respiratory virus, so you can't really actually make a direct comparison. The conclusion. So although viral hemorrhagic fever in South Africa is rare, the symptoms in the beginning, specifically for Ebola, is very, very non-specific. It's very similar to conditions we see every day, our bread and butter. So we need to identify those few and far between cases that comes from a high-risk area or was contact with a high-risk person, and we need to isolate those people, do further investigations. The last thing we want to do is admit this patient into the hospital where we have a general spread. Now, early on, I said, well, ideally, you don't want to have developed a rheumatic fever with a patient in a hospital. So what's happened is the NICD is continuously surveilling this outbreak. If a patient with Ebola is identified, it's not the patient you're going to manage in your local hospital. Arrangements are on an ongoing basis with the academic hospitals in every city, like Pretoria Academic Hospital, Charlotte Maxeke, and J.M. Joseph Hospital. So when there's a confirmed case, these patients will be transferred according in a specific transfer module to isolation units in these facilities where they will be further managed. And just because they are better geared and have support from the NICD to manage these cases. But we still have to have a high index of suspicion. Now, the information to be found, and I tested this. Quite often you find sulfur numbers and so on, but I mean, these are very variable. The NICD hotline is 24/7 manned by doctors on a call roster. Obviously, if we have some other major outbreak, this line might be quite busy. But right now, it was very easy for me to get through and get appropriate information and to talk to a doctor. These doctors form their own network on a WhatsApp group where they are in regular contact. So whenever you have a case, everybody will be informed and everybody will be there to assist you in the infection control unit of the hospital to manage this patient. It's not something that you're going to have to be able to deal with on your own. You will literally have the support of all the infectious diseases specialists in South Africa to identify. If you need information, you go to the NICD website, the specific, the index, the A to Z index, and you can click on any of these conditions, infectious conditions. You can get all the updated information. They've got a reporting sheet, which means a reportable condition. They've got PPE precautions, everything from A to Z, how to handle these conditions. So it's not what you know, is who you know when it comes to this. Right. Are there any questions?
Oh, thank you so much. We're just very glad that when it ever landed, our emergency center will be handled by you. And your knowledge is really quite very good on that. And hopefully you can divert him away from our system. But yeah, but I think, look, it's been a very scary, obviously virus. And I mean, if you watch movies like Tom Cruise, Mission Impossible, talking about creamy fever. And it's kind of, I think they've really been demonized, this virus. And you're right, that actually we do have a lot of minor outbreak in South Africa, but obviously I think they've been contained on the vet sites. But human outbreak, I think South Africa has been quite quiet for a number of years now.
Yes.
And since I started becoming a doctor, we only have one incident, which was, I think, was St. Helen Joseph, but in Barra. That was a while ago, but then since then we have nothing. So the question is that, I mean, what would be the APC when this patient arrives as a casualty and obviously to our emergency center? Obviously, looking at the emergency center is kind of very small with quite a lot of patients. What does that actually mean to those patients that probably will be exposed and then probably in contact with?
So I think basically what you do is when a patient comes into the emergency department, the first, and that's why triage is so important, and the triage staff needs to be aware of this as well. You've got a patient with any febrile illness, the first thing you should ask is travel history. I mean, this is why we often, we need to be alert for malaria, for instance. If they've traveled to the Kruger National Park or surrounding area and they've got a fever, it's malaria till proven otherwise. And if you're going to miss it, it's just sad, but malaria is, at least, is not contagious. But if you have somebody who just came back from Uganda or the DRC with a fever and gastro symptoms, and you don't pay attention to this, and you admit them to the hospital, the next day when Cornell gets to the patient and he asks the questions, you're going to get a very angry phone call. So we need, just to protect our community, we need to be, it's a huge responsibility, because we might never see a case, and we might see 10 cases, we don't know. And that makes it very So you're not going to go out and you know that later today you're going to have to give a case. And that's why we need to do these lectures and just keep ourselves up to date from time to time.
Yeah. And do you build up immunity?
Unfortunately
not.
Unfortunately not. I think it's because the exposure is so minimal. Even malaria. I mean, a lot of people say, well, develop immunity against malaria. So they say if you spend 10 years in the malaria region, you can develop a partial immunity.
Mm.
You go out of that area for a few months, you lose that immunity.
It's gone.
Yeah.
Mm.
So it's not effective.
Mm.
I'm not sure.
I know that I don't have immunity, though I grow in South Sudan, but I do have a sickle cell trait. So for communities that actually stay in that particular area, they're always having, as I say, universe always has nature its own way of for you to develop resistance against whatever is become a common occurrence in your society. But of course, for the visitors, for people non-resident areas, most of the time to develop immunity is very difficult. But at the same time, sometimes when they get the same infection for the second, third time, the robust immune response is quite better, and then they normally don't get very sick like that. Means the chance of mortality are less as compared to those who never get exposed to it.
Well, if you just take influenza, we can never develop immunity against influenza because
But it doesn't kill you either.
every year it changes.
Yes. But it doesn't kill you either.
Yeah, it's not.
Yeah. So that's a bit about, I mean, if you look at influenza 107 years ago, it kills almost everybody. It was quite little when it developed first in Spain. But then since after that now mortality for influenza actually has gotten less and it's really more become a disease of the.
But that's what I say. A virus don't want to kill its host because it's been in. So influenza is in a happy spot. And that's where COVID is now. It's like influenza. It's not happy because it doesn't make enough noise, so we want to kill it. So it can just happily coexist. And that's where a virus wants to be.
Online, anybody there? I know there are 18, 17 people sitting out there. Join us in conversation. Do you agree? Do you think we can dodge the bullet with Ebola? What is your perspective?
I can also confirm what you said about the NICD. I had I think a couple of years ago, a patient with dengue fever who also just dialed the hotline and connected with a doctor who's on call on their roster. They assisted with the necessary testing to get the samples to the NICD, and then they actually contacted me on a daily basis to track how the patient is doing, how the blood results are, and then to finally confirm it took about, I think, 2-3 days to confirm the diagnosis.
No, they're very efficient.
They
Yeah.
were really good.
I think Michelle Bloomberg has left a big legacy there.
Well, Prof was calling me actually.
Yeah, very efficient.
Yes.
Like them.
It's almost like the poison center in Cape Town, which is now Afritox on the website. I mean, if you need any information regarding toxicology, you just go onto the Afritox website where you call it poison. Now, I think the poison center is now scaled down because the internet based. But information is there, and it's just so helpful. You just go onto the website and you get all the information that you need.
All right. If there's no question, we want to say thank you. Thank you for joining us. And join us next week, Wednesday and Tuesday again, as we do another presentation. And the week after that, we have also Tuesday, Wednesday, Thursday, because we've got microbiology. Otherwise, thank you so much. Have a lovely day. Leanne, anything from you
Thank
for
you.
that?
Have a good day.
Okay, guys.
Okay, thank you.
Oh, God.